So how do bacteria become resistant? And we probably all know about the Darwinian evolution, that mutation in any gene can occur approximately in 1 cell per 10 million to give an antibiotic-resistant subpopulation. Antibiotic treatment kills susceptible population and then selects for resistant bacteria. And then, overnight, 1 cell can give 1,000 million progeny, which basically means the antibiotic-resistant population expands. So what is the impact to antibiotic resistance? Because it is ultimately going to affect us all. It can result in an increase in morbidity. Infection takes longer to eradicate as the therapy must be changed. We might not be hitting it with the right antibiotic initially, and we have to wait for cultures and sensitivity and then target therapy. Mortality may be increased where the infection isn't treated, and unfortunately the patient might die. Some drugs no longer work, so their use is restricted. And obviously we're using more antibiotics, so that's going to increase pressure. And patients have to stay longer in hospital if they do develop an infection to which the antibiotic, the bacteria is resistant. In terms of cost, I think the next slide actually shows very nicely, illustrates very nicely sort of some costs that are associated with this phenomena.
Okay, so MRSA, so that's an introduction to Staph aureus. MRSA then are exactly the same. They're Staph aureus, but they've got an extra little piece of DNA. It's a gene that encodes something called MECA, and this gene gives the bacteria the power to resist a wide range of antibiotics that we would like to treat them in. So the gene is actually on a special bit of DNA, and I'm going to talk about these a little bit more as the talk goes on. They're called mobile genetic elements, and this one in particular is called SEC-MEC. So bacteria or Staph aureus that carry the MECA gene are resistant to all beta-lactam antibiotics. So that's penicillins, the ones that we really like to use the most, which are flucloxacillin, but also carbapenems and cephalosporins, a massive class of our most favourite class of drugs that we use to prevent and to treat infection. So what happens when we have a lot of MRSA, for example, in our hospital? Well, it means that if you've got an infection with an MRSA, we can't treat you with the drugs that we want to, and we have to rely on inferior antibiotics. So the major class of antibiotics we rely on now are the glycopeptides, and the most common one is called vancomycin. And vancomycin works, but it's more toxic, it's more expensive, doesn't work as well. It's really just not as good as the beta-lactams, which are amazing drugs, so we've lost it. But also, if we have a fair amount of MRSA in our hospital, perhaps we set a threshold of about 10% of our Staph aureus infections are due to MRSA, then that means we can't use these antibiotics for other reasons that we would really like to use them for.
What is it? Tuberculosis is a disease. It's a contagious, debilitating bacterial disease that's spread by airborne droplets into the air from one infected person to an uninfected person. So the symptoms for tuberculosis start off very insidiously, simply as a cough that really won't go away, and then you're feeling tired all the time. Then gradually, as the disease develops, you start to lose weight, you lose appetite, you have fever and night sweats at night time, and the cough, although it starts initially as non-productive, ends up being a bloody sputum. So just to challenge our perceptions about the disease, it isn't a disease of ancients, and it isn't necessarily only a disease of what we call emerging economies or developing countries, as this is the image that we often see when we look on the internet or on the television. Well, actually, TB as a disease is actually here amongst us in London. And London is regarded as the capital city of TB in Europe. And this picture from the Evening Standard just about a month ago really emphasises the idea that anyone can catch TB if they happen to be unlucky enough to come into contact with an organism. Tuberculosis can become resistant to multiple drugs. And from this slide you can see that multiple drug resistant TB, or MDR-TB, there are at least nearly 500,000 cases of MDR-TB in the world. And worse than that is there are about 50,000 cases of TB that are almost untreatable because they're extremely drug resistant, not just resistant to 1 or 2 drugs, but to 7 or 8 drugs.
I'll do this very, very quickly because I think slightly different than a lot of people. I think it is important to appreciate quickly before we start, we don't live in a human world. This world is run by bacteria. You count the number of cells on our bodies, we have more bacterial cells. They'll outlive us, you shoot them into space, they'll survive. We're kind of irrelevant to an extent. So ecologically, what we're trying to do with antibiotics is really nothing compared to the stuff we're doing in the rainforest is nothing what we're doing with bacteria. I think it's worth thinking about why antibiotics are different from other drugs. They really are different, and they have different considerations and different things to use. This is a drug called Digitalis. I've chosen it because it's an old drug. Okay, foxglove, being used in there's a picture of it being used for dropsy in the 1740s. Basically, you use the same drug now, 4 centuries after it's been used before. It's going to work in exactly the same way. What you did with it then will have the same physiological effect now it's working on a human. Here's penicillin. Nice to see the same picture being used earlier, or saving a soldier. Very, very effective in the 1940s. Being slightly unfair to penicillin, it still has a few uses, but it's certainly not as effective as it ever used to be. Within 50 years, compared to the 400 we've used Digitalis, the drug isn't working as well.